Hello everybody, I'm Dr. Tanya Gursahani, JR1 from Department of Radiology, MGM Hospital, Navi, Mumbai, and my topic is Role of Ultrasound in Evaluation of Causes of Secondary Dysmenorrhea. Ultrasound is the first-line imaging modality for evaluating dysmenorrhea due to its safety, accessibility, and cost-effectiveness. It helps differentiate primary from secondary dysmenorrhea by identifying pelvic pathologies such as fibroids, adenomyosis, endometriosis, ovarian cysts, and congenital uterine anomalies, guiding appropriate management. The aim is to study the role of ultrasound in identifying causes of secondary dysmenorrhea. The objectives include to evaluate uterine and adnexal pathologies, to identify the common etiologies, and to correlate imaging with clinical findings. This is a retrospective study done in MGM Hospital, Kamote, Navi, Mumbai. USG studies of 6 patients with complaints of dysmenorrhea were identified. Patients' age ranged from 20 to 35 years were referred for imaging. All patients were scanned on Samsung V8 USG machines using curvilinear transabdominal and transvaginal probe. The results are as follows. Case 1. 29-year-old presented with dysmenorrhea. The uterus is bulky, measuring up to 9 into 4.6 into 6.6 centimeters, with the endometrial thickness being 7 mm, with a focal heterogeneously hypoechoic area, with few cystic areas within, measuring 3.9 into 3.9 centimeters, noted along the anterior wall with a Venetian blind appearance, showing increased vascularity on color Doppler examination, suggestive of focal adenomyosis. Case 2. 32-year-old presented with dysmenorrhea. The uterus appears bulky and heterogeneous, showing raised vascularity on color Doppler examination with a Venetian blind artifact, suggestive of adenomyosis. Also, a 2 into 1.8 centimeter sized intramural fibroid along the anterior wall of lower uterine segment is noted. Case 3. 27-year-old presented with dysmenorrhea. A 3 into 2.4 centimeter sized, well-defined, rounded, hypoechoic lesion with minimal peripheral vascularity on color Doppler examination is noted within the cervical canal, likely arising from the anterior wall, suggestive of a cervical fibroid. Case 4. 30-year-old presented with dysmenorrhea. A 4.6 into 4.2 into 3.3 centimeter sized, well-defined, rounded, smooth marginated, echogenic solid lesion within the endometrial cavity at the fundic region is noted. It shows mild peripheral vascularity and internal vascularity in the form of a prominent central vascular pedicle arising from the posterior uterine wall. Possible radiological differentials include endometrial polyp and submucosal fibroid. Case 5. 27-year-old presented with dysmenorrhea. There are 2 1.3 into 0.5 centimeters and 0.8 into 0.5 centimeter sized, well-defined, ovoid, homogeneous, echogenic solid lesions with a stalk, separate feeding vessels, each noted on color Doppler examination in the endometrial cavity, suggestive of endometrial polyps. Right adnexa. There is a 4.8 into 3.5 centimeter sized, well-defined, thin-walled, rounded, anechoic cystic lesion noted in the right ovary with lace-like internal echoes within, showing no evidence of internal vascularity on color Doppler examination, suggestive of a right-sided ovarian hemorrhagic cyst or RADS2. Case 6. 25-year-old presented with dysmenorrhea. There is a 3.8 into 2.4 centimeter size thick-walled cystic lesion with lace-like echoes and peripheral vascularity on color Doppler examination noted arising from the right ovary, suggestive of a hemorrhagic ovarian cyst. The right ovarian follicles appear to be peripherally displaced. The USG features are likely suggestive of a hemorrhagic ovarian cyst. Case 7. 26-year-old presented with dysmenorrhea and left flank pain. There is a 3 into 2.7 cm sized, well-defined, anechoic, thick-walled cystic lesion noted in the right adnexa, likely arising from the right ovary, with fluid level and ground glass echoes seen. Possible differentials include endometrioma and hemorrhagic cyst. Case 8. 27-year-old presented with dysmenorrhea, fever, and pelvic pain. The patient also presented with adnexal probe tenderness. Mild free fluid mobile internal echoes were noted within the pouch of Douglas. Possibility of pelvic inflammatory disease to be considered. The dominant follicle was noted in the right ovary. Dysmenorrhea is commonly associated with underlying pelvic pathology and requires accurate evaluation for appropriate management. USG plays a central role as the first-line imaging modality in assessing women with suspected secondary dysmenorrhea. Its widespread availability, non-invasive nature, cost-effectiveness, and patient accessibility makes it an essential tool in routine gynecological practice, particularly in resource-limited settings. USG aids in differentiating secondary dysmenorrhea from primary dysmenorrhea by enabling early identification of organic causes. This early assessment has reduced delays in diagnosis and allows timely initiation of targeted treatment. By providing objective information, USG supports clinical decision-making and assists in selecting patients who can be managed conservatively versus those requiring further investigation, referral, or intervention. In cases where clinical examination and lab findings are inconclusive, USG adds significant diagnostic value and improves overall diagnostic confidence. It also plays an important role in follow-up, allowing monitoring and treatment response and disease progression over time, thereby contributing to comprehensive patient care. Despite its advantages, USG has certain limitations, including operator dependence and reduced sensitivity in specific conditions. Nevertheless, it remains an effective screening tool that guides the need for advanced imaging or invasive diagnostic procedures when necessary. Conclusion: USG is an indispensable first-line tool in the evaluation of secondary dysmenorrhea. Its accessibility, safety, and cost-effectiveness enable early identification of underlying pelvic pathology, guide clinical decision-making, and optimize patient management. When integrated with clinical assessment, USG significantly improves diagnostic efficiency and patient outcomes. Thank you.